Beginning, there were 3 different germ layers, all stacked on top of each other like a meat Oreo, and they were called the ectoderm, meaning outside, mesoderm, meaning middle, and endoderm, meaning inside. 3 guesses as to which one makes up the GI tract. Anyway, these layers didn't end up staying Oreo-shaped for long. The layers all started to curve around the sides until finally all 3 layers were wrapped up more like a meat burrito than a meat Oreo. The important thing to realize is that the ectoderm and the mesoderm wrap around the growing GI tube, sort of like this, until they come together at this opening right here. Any idea what this is? Well, right here is where the primitive gut communicates with the yolk sac, which is important early on, but the most relevant thing that comes through this opening is going to be the umbilical cord, this little pink doodad slipping through. And that makes this the umbilical ring. Now this is one of the busiest sites in GI development, but it's also the place where the most things can go wrong. So let's take a close look at this process by turning this midline sagittal section into an antero-posterior view. So now we're looking at the embryo like this, assuming we fast forward 8 months or so to the finished product. Here's a schematic diagram of the embryo before complete fusion of the anterior wall, and like I said, it all revolves around fusion with the umbilical ring. In order to do this, the ectoderm and the mesoderm come at it from all 4 sides. From the head, or the rostral direction, from the tail, or the caudal direction, and from both sides, or the lateral directions. The junctions with which they fuse with the umbilical ring are known as the rostral, caudal, and lateral folds, respectively. Now, the ectoderm, among other things, makes the skin, and the mesoderm makes most of the rest of the body wall, including the muscle and bone. So you can imagine what kind of badness happens if any of these 4 folds doesn't close. It makes sense anatomically. A defect of the rostral folds can lead to sternal defects, and a caudal fold defect can cause an opening in the anterior pelvic wall, leading to bladder exstrophy, which is basically a bladder outside of your body. Gross. Anyway, this being the GI section, what we're most interested in is a failure of lateral fold closure, because this is what makes up most of the abdominal wall. Failure to close can lead to gastroschisis, a complete defect in the abdominal wall that allows the intestines and some of the other abdominal contents to herniate through that opening. For some reason, defects of the right lateral fold are more common, so you tend to get a right gastroschisis. Anyway, back to our story about where the guts come from. Even from its days of being a little green tube, the gut can be functionally and anatomically divided up into 3 regions based on the blood supply. The celiac artery supplies the foregut, the superior mesenteric artery supplies the midgut, and the inferior mesenteric artery supplies the hindgut. The foregut is the precursor of everything in the GI tract from the pharynx to the duodenum, including the solid GI-associated organs that secrete stuff into the duodenum, namely the liver, gallbladder, and pancreas. There's one other organ supplied by the celiac artery, though, that isn't derived from foregut endoderm. Remember which one? This is kind of a tricky one. While the spleen is supplied by the celiac artery and is in close proximity with the liver and pancreas, it is not a GI-associated organ and therefore is not derived from foregut endoderm, but rather mesoderm. The hindgut is actually a pretty small part of the GI tract and is only the precursor to the distal 1/3 of the colon, the rectum, which is practically just distal colon, and the internal portion of the anus. We'll discuss in the anatomy section about what qualifies as internal and external anus. Now that leaves just the midgut, with by far the largest amount of hollow organ volume to generate. It's responsible for the majority of the small intestine and the colon. In you or me, that'd be about 26 feet of intestines. And even though it's just baby intestines, and even though the little embryo schematic isn't drawn to scale, you can probably guess that there's not enough room in that little baby tummy for all those intestines to be made. So what happens is, the midgut herniates through our favorite opening from the previous section, the umbilical ring, starting about the 6th week of development so that it can have more room to grow. It actually generates most of the length of the small intestine outside the abdominal cavity. Now, the aqueous environment of the uterus is an awesome place for intestines to grow and hang out, but sooner or later, you gotta pack all that organ meat back up into your baby. By the 10th week, the baby's abdominal cavity has grown a fair bit, but in order to pack that small intestine into such a tight space, the whole mass has to rotate 270 degrees counterclockwise around the axis of its blood supply, the superior mesenteric artery, before it can return to the abdomen. Now, as you can imagine, this is a pretty complicated song and dance for a bowel that's not even intelligent enough to poop yet. As a result, a bunch of things can go majorly wrong. There's 2 of these things that you'll be likely responsible for. Omphalocele, which is a result of the failure of the intestines to correctly rotate and reduce into the abdomen, leading to something like this. And yes, you guessed it right, that is a big sack of guts lying on top of the belly button. It's covered in a thin layer of mesentery that eventually becomes the peritoneum. Compare this to gastroschisis, which is just a piece of naked bowel popping out near the side of the belly button without a peritoneal covering. You'd think that at least having some bowel covering would be better than none at all, but actually, omphaloceles are usually associated with trisomies or other developmental syndromes that makes these kids' prognosis pretty terrible. The other problem involves twisting the gut around that poor superior mesenteric vessel so much that it just gets twisted shut, causing the bowel to either atrophy or be resorbed in a process known as intestinal atresia, specifically of the jejunum or the ileum. We'll talk about that a little more, but as you can imagine, there's a lot of problems that come with having a foregut that doesn't connect up to the hindgut. Alright, first question of the day. What is the name of the ventral wall defect that involves herniation of the intestines not covered in peritoneum, usually to the right of the umbilicus? The answer, my friends, is gastroschisis. And always remember, compare this to omphalocele, which is a protrusion of the intestines through the umbilical ring, not to the right, which is covered in peritoneum. Let's talk a little bit about the development of the trachea. You already know about where the esophagus comes from, but the kind of neat thing is, the trachea too is derived from foregut endoderm. No kidding. Shortly after the esophagus establishes communication with the mouth, the trachea begins as an outpouching of the esophagus before budding outward into the lung buds. Now normally, a septum forms to divide the trachea from the esophagus by sort of pinching itself in laterally, creating two completely independent tubes connected only by the larynx, right here. Compared to the whole twisty-twirly in and out thing the midgut does, it doesn't seem like such a complicated exercise. But as it turns out, the septum has a whole bunch of ways that it can potentially screw the pooch. The most common way, believe it or not, is for the septum to go totally overboard and pinch itself all the way to the back wall of the esophagus, proving once and for all that the embryonic trachea is a complete idiot. This is most specifically known as esophageal atresia with distal tracheoesophageal fistula, and there are two main consequences. First, and most obviously, you can't swallow anything when your esophagus ends right here. In utero, this means that the fetus can't swallow amniotic fluid, so it accumulates, causing polyhydramnios. When the baby's born, any feeding leads to immediate regurgitation, and since the saliva secreted by the mouth has nowhere to go, babies will drool and choke, even without feeding. The second main consequence is that since the distal esophagus is connected by a hole in the airway, the moment the baby starts breathing, air is going to start to be pushed into the distal GI tract. And this is visible on X-ray as well. Of course, this goes the other way too. Guess what happens if you inflate the stomach with too much air? You got it! Burps aplenty. Except these burps go into the airway, as opposed to into the proximal esophagus, which makes those gross baby burps that are accompanied by a little puke just a little bit more dangerous. There are a couple other types of tracheoesophageal abnormality that aren't at all as common as the types we just talked about. Pure esophageal atresia is the first one, which presents similarly but without the gastric air. And pure tracheoesophageal fistula, where the esophagus is actually patent, but there's a connection with the trachea. This doesn't really have the same degree of instantaneous regurgitation as the others, but there is still a very real risk of aspiration and resulting pneumonia or respiratory distress syndrome. As it turns out, the esophagus isn't the only part of the GI tract that can undergo atresia, as I'll illustrate shortly with my amazing anatomically accurate diagram. Duodenal atresia occurs because during the development of the duodenum, the lumen gets temporarily obliterated because the cells inside are proliferating so fast they just plug it up. And that's all well and good for a little bit, but if the lumen fails to open back up or recanalize, then you've got a bowel obstruction, this time at the level of the duodenum rather than the esophagus. This commonly happens to kids with Down syndrome, and actually a whopping 20 to 40% of all kids who get duodenal atresia are Down's babies. The mechanism of jejunal or ileal atresia, or atresia lower down in the small intestine, is a little different. As I mentioned before, these atresias are caused by vascular compromise. Now, in an adult, an area of ischemic bowel will straight up kill you with peritonitis, but in the relatively sterile infant bowel, the segment of ischemic bowel just gets broken down and resorbed by the rest of the dividing tissue, because when you're growing that fast, ain't nobody got time for a bowel that doesn't pull its weight. Funny fact, when a segment of bowel is missing, the proximal end will form a little pouch like you see here. But the distal end near the cecum will often form a curlicue, like a little pig's tail, leading to the name apple peel atresia. Now, this doesn't always happen, but both duodenal and jejunal atresia have characteristic X-ray findings that are good buzzwords to remember for the test. Since both types of atresia are characterized by blind endings to the GI tract, they tend to get pretty distended with air. In the case of duodenal atresia, air collects in the stomach and the duodenum proximal to the atresia, but the pyloric sphincter in the middle continues to divide the two up, and this leads to the famous double bubble sign on X-ray. In the case of jejunal atresia, air collects in the stomach, the duodenum, and the jejunum, with a ligament of Treitz and the pyloric sphincter dividing the bubbles up. This leads to the far less poetic sounding triple bubble sign. With duodenal, jejunal, and ileal atresia, just like with esophageal atresia, the first sign is usually polyhydramnios in utero. When these babies are born, they won't even be able to keep their first meal down, though infants with ileal atresia will be able to keep their meal down longer than those with duodenal atresia. And the kids with esophageal atresia puke pretty much as soon as the food hits their mouth. But a key distinguishing factor that you should remember is that duodenal, jejunal, and ileal atresia all cause bilious emesis, meaning it's green, as opposed to esophageal atresia, which is non-bilious. On the pediatrics floor, this is considered a pretty important distinction for knowing where the site of the obstruction is, and really, it's just simple anatomy. Remember, the bile from the common bile duct leaves the sphincter of Oddi at the second part of the duodenum. So it stands to reason that obstructions distal to the sphincter of Oddi will cause bilious emesis, whereas obstructions proximal to the sphincter of Oddi will cause non-bilious emesis. The only non-intuitive one to remember is duodenal atresia, and you just need to remember that duodenal atresia generally occurs in the third and fourth parts of the duodenum, which makes it distal to the sphincter of Oddi. The other thing that's true about all the atresias that I just mentioned, and that I hope is obvious, is that all of them require immediate surgical intervention. Having a GI tract that stops and starts is not an abnormality that's compatible with life in the long run, especially the tracheoesophageal abnormalities. So a pediatric surgeon needs to be able to go in and establish the anastomoses that should have formed during fetal development. But hey, we haven't even gotten to the most common cause of infant GI obstruction. Hypertrophic pyloric stenosis is more common than any of the gastrointestinal atresias, and it's a very different kind of obstruction in a lot of ways. First, while the atresias tend to happen early in utero, causing symptoms soon after the first feeding, hypertrophic pyloric stenosis involves a slow, excessive growth of the pyloric sphincter, the gateway sphincter into the duodenum. Because the obstruction develops over a period of time, pyloric stenosis only starts to cause problems between 2 to 6 weeks of age, about a month on average, unlike the atresias that generally present soon after the first feeding. The presentation for this disorder has two key buzzwords that you need to remember. First, there may be an olive-shaped mass palpable in the kid's epigastrium. Second, while all of the atresias lead to vomiting when the kid tries to feed, you'll often hear the term projectile vomiting used to describe the kids with pyloric stenosis. This, by the way, is one of the many reasons I didn't go into peds. Anyway, if you had to guess, would you describe the vomit as bilious or non-bilious? Non-bilious, right? If the bile is secreted right here, and the obstruction is right here, then it's not going to be able to leave the esophagus as vomit, projectile or otherwise. So, how can you predict if your kid's going to be the next star of The Exorcist? Well, nobody really knows what makes the pylorus grow that fast, but there are a few associations that you should be made aware of. Firstborn children and males are more likely to get hypertrophic pyloric stenosis, as well as infants that were given macrolides soon after they were born. So, no macrolides for kids if you can help it. Finally, just like the atresias, the treatment for this condition is surgical, and the operation is specifically called a pyloromyotomy because it's an incision in the pylorus. We'll wrap this section up by talking about the spleen and the pancreas. Now, you already know a lot about these two, right? So, what major arterial trunk are they supplied by? Like I mentioned earlier, the celiac artery primarily supplies both. And what's their embryologic origin? This one's a little trickier. The pancreas, like its buddies the liver and the gallbladder, has its roots in endoderm, specifically the foregut endoderm. The spleen, however, throws this logic into a loop. It's supplied by the celiac artery, but it's actually derived from abdominal mesoderm. And this is an important exception to remember because it's the only mesodermal organ supplied by one of the three major vascular trunks of the aorta. And you know the drill. If it's weird, step one likes to ask about it. Let's talk a little bit more about the pancreas, because we end up talking about the spleen in the immunology section. The pancreas is generated from the duodenum in two little buds, the dorsal and ventral buds, that actually form from two different outpouchings of the duodenal endoderm. That means that there are two separate openings through which pancreatic enzymes can drain. As the fetus matures, the dorsal pancreas grows to become the major bulk of the pancreas, while the ventral pancreas is tasked with traveling behind the duodenum to join the dorsal pancreas. By now I think you guys are starting to see a pattern. Whenever an organ has to move or twist or do anything besides just sit there and grow, there's always a way that it can be screwed up. If the pancreas tries to wrap ventrally around the front of the duodenum, or be completely stupid and wrap around both ways at once, the end result is you end up constricting the duodenum with either the duct or with a weird ring-shaped pancreas, aptly named the annular pancreas. It usually causes a minor obstructive pathology of the duodenum that's not quite as severe as full duodenal atresia. The ventral pancreas fuses with the base of the dorsal pancreas to form its uncinate process, and here's the weird part. Even though the dorsal pancreas makes up the vast majority of the pancreas, namely its head, body, and tail, the ventral pancreatic duct ends up being the main outflow of the pancreas. That means that if the much larger dorsal pancreas wants to have any shot at a normal outflow, it has to divert its flow through the ventral pancreas. This larger outflow tract is called the main pancreatic duct, and it drains into the major papilla, whereas the little dinky tract coming off the dorsal pancreas is the accessory pancreatic duct, and it drains into the minor papilla. If for some reason the pancreatic buds don't fuse, it's called pancreas divisum. So what happens then? Well, usually nothing. Logically, you might think that without any ability to connect to the major papilla, the dorsal pancreas will have an outflow tract that's far too small to accommodate its output. Occasionally this can cause chronic pancreatitis and abdominal pain, but the ducts can usually adapt to the rate of flow, making this condition generally asymptomatic. Alright guys, now that I've got you armed with all the knowledge you'll need for GI embryo, let's wrap this up with a flash quiz. So, here's a good one to wrap up this section. Name 3 congenital anomalies that can lead to bilious vomiting in infants. Go ahead and pause the video if you need some time to think. So, the key is to think of this anatomically. Bile is secreted into the second part of the duodenum, so clearly jejunal and ileal atresia can lead to bilious vomiting. Duodenal atresia usually exists in the third and fourth parts, so it's important to remember that duodenal atresia usually leads to bilious emesis, even though it isn't as intuitive as jejunal or ileal atresia. And that's all I got for you, eggheads, at least as far as embryology goes. Future surgeons, get your scalpels out for one of the highest yield anatomy sections in the book. GI anatomy coming up next. In the meanwhile, if you like this video, go ahead and let me know by giving me a thumbs up down below. And as always, comments are very much appreciated. This is Arjun.